Well, hi, everyone. Welcome to the Sports Science Institute Spotlight on Mental Health Action Plans, which is a two-part series. My name is Brian Heinlein, the NCAA Chief Medical Officer. Always good to be with you. So this two-part series is really providing an overview of the recently released second edition of the NCAA Mental Health Best Practices, which was put together under the supervision of the Mental Health Advisory Group and ultimately endorsed by the Board of Governors for this to move forward as part of our legislation. So we're going to really be focusing in these next two series on the full spectrum of mental health care, from identification of student athletes with mental health symptoms and conditions to ongoing treatment, follow-up, and reentry when indicated. I just want to take you through a couple of slides to review where we are. So the legislation for the NCAA is to have mental health services and resources available consistent with the mental health best practices. So recall, this was voted on by the Board of Governors in January. We've been giving you a lot of information about these best practices, and they become effective this upcoming academic year in August 2024. In addition to making services and resources available, the legislation states to distribute mental health educational materials and resources to student athletes and include a guide to mental health services and resources, basically on how to access them. And all of this is in the second edition of the Mental Health Best Practices. So one of the things we did with the best practices, we kept the four core themes, but we just reorganized how we place them. So the first theme centers around a bunch of best practices about creating a healthy environment that supports mental health and well-being. The second theme is identification of student athletes with mental health symptoms and conditions, primarily by way of screening. The third theme are action plans for both routine and emergency mental health care. And then the fourth theme is identifying those who are licensed to provide mental health care. So you can take a quick camera shot of this QR code, and that will take you right to the landing page of the mental health best practices, or if you don't have your camera handy, you can still always get these on nca.org and under Sports Science Institute. We're going to focus really on the best practice number 3, which is about action plans that outline referral pathways of student athletes to qualified providers. And these action plans address the full spectrum of care, including emergency and routine mental health care. And importantly, these action plans should be both written and rehearsed. I want to introduce our two esteemed guests. So Dr. Claudia Reardon, a professor at the University of Wisconsin School of Medicine and Public Health and in the Department of Psychiatry. And importantly, Claudia also is co-director or co-chair of the International Olympic Committee Consensus Meeting on Mental Health and Elite Athletes. Part 2 is going to take place in June of 2025. And Kim Terrell, many of you know, she's been an active member in the Committee on Competitive Safeguards and Medical Aspects of Sports, and a Senior Associate Director of Athletic Medicine at the University of Oregon. So Claudia and Kim, thanks so much for being with us, and let's just move right in. So, you know, when we look at the best practice number 3, it recommends that all schools have written and rehearsed mental health action plans, well-defined pathways to mental health care, including routine and emergency mental health care. And it states that the action plan should address the full spectrum of care, which begins with identifying student athletes with mental health symptoms and conditions to ongoing treatment, follow-up, and importantly, reentry when indicated. So maybe just describe, Claudia and Kim, when we say the full spectrum of care, what does that mean for you?
I can go ahead and start because I feel like this question resonated with me quite a bit. I think that it really begins when student athletes first visit our campuses and providing them with a sense that there is a supportive environment, not only for their physical health, but also for their mental health. Certainly when a student athlete joins the program and the onboarding process, that certainly is a really good time to touch on their history and also allow them to know what resources are available to them. So I think that the spectrum of care begins when we meet the athlete. There certainly needs to also be a culture that promotes mental health awareness and education, not just with the student athletes, but also with the coaches and the staff.
Well, I completely agree with you, Kim, and I appreciate that perspective and the focus on the mental well-being, the whole continuum from well-being all the way to mental health symptoms and disorders. And as a psychiatrist, I of course tend to focus on caring for the athletes when they're more on the mental health symptoms and disorders part of that continuum. But I think it's important to think about all of the different layers of mental health care that are available. Starting with routine mental health care in the outpatient setting, seeing mental health counselors, psychiatrists, dietitians, any other members of the multidisciplinary care team who may be involved in providing mental health care and support for our student athletes. And then sometimes we need to include higher levels of care, whether that's outright hospitalization for these disorders or other higher levels of care. And then if treatment necessitates a break from sport, as Dr. Haline alluded to, thinking about how are we going to help support the athlete with re-entry into sport and doing that in a safe and healthy way.
So that's really helpful. And, obviously when we're talking about the full spectrum of care, it's for our student athletes. But when we're laying this out at the campus level, who do we include in making certain that all of the appropriate people are aware of the full spectrum of care? And how do we best sort of integrate that and operationalize it at the campus level?
Well, this is a really important question. And obviously the athletes need to be at the center of this. The athletes need to be aware of the services that are available to them. But then everyone surrounding the athletes who's at all possibly involved in their care and helping to establish an environment of wellness needs to be part of this as well. So we need to certainly include coaches, definitely athletic trainers, the team physicians, sports medicine doctors, dietitians, strength and conditioning personnel, academic support, anyone who really has a significant contact with the athletes should be involved in and aware of the mental health programming and resources that are there.
And Kim, you're at the ground level. You see this every day, and you've seen the variations of themes across many schools through your work on competitive safeguards. I mean, how do we really get? Claudia mentioned an awful lot of people that need to be involved. How do you really operationalize that at a campus level?
I think it starts with having a core team who are aware, responsible, and communicating regularly and meeting regularly to ensure that that education across all of those groups is happening and that those conversations are being had. I think one of the things in athletics that's the most difficult resource to manage is time. And so being really pointed in how you address bringing this group together and targeting that, what is their role? What is it that they need to know specifically? Or what do they need to feel supported in this area? Because I think many of the people that Dr. Reardon mentioned aren't 100% secure in the mental health space in terms of how they communicate and what they communicate. So helping them know their role and understand and have the education to feel confident in how to manage situations that occur and how to create those positive environments that we're so hoping that our athletes experience. But we know that the stress and the demands of what is placed on them is going to potentially cause them some mental health challenges during the time that they're participating. I think coordination is probably one of the more difficult, but what I've found is that a diverse, smaller group, so not just athletic trainers. I want to call that out specifically. This isn't something that just athletic trainers can really take on and manage. This requires the input and guidance and support of multiple professionals within campuses. And so it might be a diversity, equity, inclusion influence or person who's in that role who can help tailor this program to some of our athletes at risk. And I also want to include student athlete leadership because they have a really strong influence on each other, and as peers can really be helpful in identification and creating a positive environment.
I'm going to really focus on two things you just said, Kim. One is, and I'll put it maybe less eloquently than you did, let's just not dump all of this on the athletic trainers. And we've seen that happen day in and day out. Like, okay, you know, they don't even use the proper word, trainers just take care of this, and that's what we see happen. And it's impossible for this one group of clinicians to handle all of the responsibility. So that's really critical. And I really like how you brought in the student athlete leadership, the student athlete advisory committees on every campus, and sort of really standing up for mental health as a right, a privilege, as something that we should all be taking care of. So really love those points. My next question, at risk being a little simplistic, or just creating an arbitrary dividing line, but when we're talking about the full spectrum of care, how do you think about it in terms of routine mental health care on the one hand and emergency mental health care on the other hand? And by emergency mental health care, when I say a mental health emergency, we're talking about the same thing as a medical emergency, like cardiac arrest that can lead to death. So a student athlete or someone becomes acutely psychotic or delusional, or is suicidal, is homicidal, has just been a victim of violence, interpersonal violence of some sort, or is suffering from a drug overdose. Things that really are red flags that need to be addressed on the one hand versus routine care on the other, although there is a continuum, right? But if we simplistically divide those two, how do you separate them and address them, or do you put them all together?
Well, I can address that. It's an important point, and I think we do need to define upfront what we are typically considering a mental health emergency, because not everyone knows what that is, and you feel like, well, I'll recognize it when I see it, but not necessarily if you're not used to dealing with this day in and day out. So I think having on paper, here are the things that generally constitute a mental health emergency. Suicidality, generally with a plan of how that would happen, or homicidality, or acute victim of sexual assault, or severe agitation or threatening behavior. These are, or the other examples that you mentioned. So to have that delineated as part of your emergency mental health action plan is really important. And what is the unifying factor of all those things? Well, it's that someone's life is in danger. In the very near future, someone's life is in danger, and we need to act now. This can't rely on our routine process of referral, which might get you in with a mental health counselor in a week. You know, that is not going to be good enough for a mental health emergency.
Yeah, that's great, Claudia.
Yeah.
Identifying at the front end so everyone understands that. Kim, how realistic is that at the campus level? I mean, all emergencies should be pretty clear, just like fire drills should be pretty clear. When there's a fire, that's an emergency. How realistic is it that we get the athletics departments, the student athletes, to really understand these are mental health emergencies? We need a plan to address these.
I think it's very realistic in a sense, as Dr. Reardon mentioned, having criteria that people can understand which pathway we're going down. I think athletic trainers and physicians and those who deal with acute injury are very used to action plans around different cases and types of injuries. So to me, this is very similar to that in the sense of, you know, a screening question might be, is this athlete a danger to themselves or others? And then that would sort of take you to which aspect of which end of the spectrum are we going to here? Is this an emergent? If the answer is yes, or even if it's maybe, that's going to activate a different type of plan than no, they're not in immediate danger to themselves or others, and I can manage this in a less acute way. I think the other difference is just what resources do you need in the moment? So if I'm dealing with a physical injury, I might need an ambulance, and if I'm dealing with a mental health emergency, I might also need emergency medical professionals to help with the situation. So I think identifying the type of situation and then having a plan that's appropriate for that lends itself to sort of a decision tree type approach to which part of my action plan am I going to implement.
And Claudia, you said something which just resonates so true. It seems kind of obvious, but when we think of it this way, it's very compelling. Someone's life is in danger when you have a mental health emergency, either the individual going through the emergency or with homicidal ideation, someone else's life. So when we have someone who's in acute sepsis or there's a cardiac arrest or is having such severe breathing difficulties that they need to be intubated, we don't think twice about the fact that this person needs emergency medical care. And when there's a mental health emergency, there must be a plan that that individual is seen immediately. This is not, okay, well, here's the number to call and here's a psychologist or psychiatrist who's on call. It is treated fundamentally differently. And I don't know if you want to elaborate further on that, distinguishing that from when someone's feeling depressed, but it's not at the level of an emergency.
Right. I think this is an important point. The disorders that we're talking about here, the mental health disorders that constitute emergencies, are real and life-threatening, and there's treatment that works. And so there should be no hesitation to seek out that treatment. And Kim had said, if it's life-threatening, if it's yes, or even if it's a maybe, then err on the side of seeking out prompt medical treatment. And I think that is an important point to emphasize, that we shouldn't get bogged down in, the concerns about, well, I don't want to unnecessarily reach out via our emergency protocol if that's not necessary. Better to err on that side, and we can figure out if it's an emergency or not from there. But better to get prompt treatment when in doubt.
And then on the other side, there's our routine referrals. And, our surveys tell us, Kim and Claudia, that there are many student athletes who don't really know where to go for routine referrals. And so how do we get that embedded into every school? I think it's highly unlikely that a student athlete would say, well, I sprained my ankle, I don't know where to go to. But it's still the case for a sizable number of student athletes with regard to mental health symptoms and disorders. So maybe just take us through how that becomes embedded in everyone's consciousness, and it's just routine care like for a sprained ankle.
I could start by just mentioning what we talked about earlier, which is about sharing how to access resources. And earlier, Brian, you put up a QR code, and something as simple as that athletes can take a picture of with their phone and get access immediately to what resources are available. Those kinds of things are easy for them to remember, to understand, and they don't have to ask their roommate or their coach or someone that maybe they aren't quite comfortable yet with talking with. Hopefully they are, but I think the easiest way is to put those resources out to them in multiple settings, have them hear from multiple people where the resources are. I still predominantly, when athletes come to me and say, I'd like to see a mental health provider, it's almost probably 60% of the time they say, my teammate told me I should talk to you. So I know that they're speaking to each other and supporting each other. And so again, that's always a good pathway to get information to athletes.
Sorry.
I was just going to say, posters with QR codes are exactly how many of our athletes get connected with mental health services. And we have these things hanging all over the place for athletes to use and get connected that way. And wherever and however we can advertise our mental health services and availability, I think is a positive thing. Here at my university, we've gone to a model of each sports team having a mental health liaison, typically in the form of a psychologist, perhaps a different discipline of a licensed mental health clinician who is identified as that particular team's liaison. And they are present often at practices, at various team functions, and they become a recognized and trusted source of mental health support. When in doubt, if there's a question from an athlete about how can I and should I connect with mental health services, they go to that person. Just anecdotally, since we added a liaison to one of our teams that historically has not readily sought out mental health services, we quite promptly saw a quadrupling of members of that team reaching out for mental health care. So I think this is the kind of thing that works.
Yeah, great. And I was just going to say what a great idea it is to have the QR code in different parts of the campus and that it's always accessible. I want to switch gears to screening. So in the first edition of the Mental Health Best Practices, we gave some recommended screening tools. It was sort of a bit of a softer call in terms of where to go with screening. But this second edition is much more explicit, saying mental health screening should be part of what a student athlete goes through, and not just necessarily on a one-time basis. It could be 2, 3, 4 times. So, Claudia, you've been at the forefront of screening. So one of the offshoots of the first edition of the ILC mental health consensus statement on in elite athletes, there was a working group that actually looked at a first ever sports specific screening tool. But maybe walk us through how you see screening, just how maybe from a academic or background principle, how it's evolved over time and how it really can become useful or impactful for our student athletes.
Well, you can't treat what you don't identify as a problem. And so screening is a really good, rigorous way to make sure everyone is being assessed for mental health symptoms and disorders, which we know to be painfully common. And I think it is becoming increasingly appreciated, where as part of preseason physicals in the past, we'd ask screening questions to ascertain cardiac risk. Now we're getting to a place of course, we should do that for mental health risk as well. And so indeed, the IOC developed this tool, this comprehensive set of tools, really, in the form of what's called the Sport Mental Health Assessment Tool. And it includes a number of well-established, well-validated tools for a variety of different mental health disorders. And I think those tools serve as a good starting point. If you're interested in what's a reasonable screening tool for depression, you can use the depression screening tool that comes from that package from the IOC, for example.
Yeah, and just I want to elaborate on that. So it's sometimes called the SMOT, but the Sports Mental Health Assessment Tool. But there's also, I think it's overlooked sometimes for coaches and non-clinicians, the Sports Mental Health Recognition Tool. It's kind of like a green light, yellow light, red light, that if you're in that red light zone, you don't leave that individual until you have done a handoff with someone else. Can you speak to that? It's not technically a screening tool, but it's sort of it's really connected to it.
Right, and it helps non-licensed medical professionals, people other than licensed medical professionals, know the kinds of things to look for that may indicate mental health symptoms or disorders. So these are the kinds of things where if I'm seeing these in an athlete, I should probably reach out to my mental health colleagues and see what sort of assistance may be needed.
So Kim, Claudia talked about the importance of screening. We do in the second edition. What's the reality on campus? There's a lot of athletes and a lot of people to do on which we do physicals. How does screening, or how can it get incorporated at the beginning of the season, but maybe even at other times of the season?
Yeah, it's easy to think about our structure and to say, when we onboard student athletes and we're doing all of this intake, that's a great time to do screening, which if it is in some situations, but I also think that student athletes are under a tremendous amount of sort of stress at that moment and may just click no to everything. We find a lot of times, even on their physical history, health histories, they don't always acknowledge all of the things that are going on with them because they're so nervous and worried about what the outcome will be. And so it may strengthen the idea of letting athletes integrate with their team and then performing some type of screening at a date that isn't actually their first day on campus or their first day with their teammates. I think sometimes they're more, they can learn more about what mental health, the value and importance and how it's a primary focus of our program, and then do some screening and maybe get a little bit different answer. So I don't think it always has to be at onboarding. I think it can be at different time points. Certainly we have clinicians who use those screening tools or abbreviated versions of them when an athlete's going through a long-term injury or suffering a situation maybe of multiple injuries. So there's different time points in an athlete's career where it makes sense to utilize tools to sort of see where they are and maybe make some decisions about what is going to be incorporated in their care. And oftentimes, just assuming that first, week isn't always that may not be the time to do the screening if you can organize it. I know our behavioral health director likes to go to a team meeting and then have people complete forms or screening tools on their phones at that time. Because the other challenge with electronic screening is athletes will do it at 2 a.m. or whenever they decide that this is the time they want to finish their screening tool. And there may not be someone available if they do need some immediate follow-up at that time. Someone may not be watching their responses. So we try to coordinate those screenings to go at a time when there's support and there's people who can then manage what the outcomes are of those screens.
Yeah, thanks, Kim. So you mentioned, we may consider screening if an athlete has had an injury, a prolonged injury, multiple injuries. And maybe Claudia, speak to this a little bit broader than that even. We know that athletes are human beings, that many of their mental health symptoms and disorders aren't necessarily related to sport. It might be the breakup with a significant other or the loss of a loved one or financial hardship or academic hardship or being outed for something. There are all sorts of stressors. How do we look at those stressors in a community and decide that we may need to do screening more than one time a year?
Absolutely. It's a good question. And so, I can say personally in my psychiatric practice working with athletes, I give them the PHQ-9, a depression screener, and the GID-7, an anxiety screener at every single visit that I have with them. So that's not necessarily typical for, all comers in terms of student athletes, but when you're talking about a psychiatric practice, I think that makes sense. From the larger athletics population standpoint, here we do the pre-participation surveys for mental health symptoms and disorders, and then once at the midpoint of each semester as a bare minimum. So athletes are given screeners at those time points. And we have found generally mid-semester can be a high stress time, and that has been high yield in terms of capturing some folks that hadn't been connected with mental health services, maybe screened okay at the preseason physical, but things turn up then. And I think our team doctors do a really good job when they're having visits with our athletes for other general medical conditions, if they're noticing mental health symptoms that appear to be surfacing, or if there are these high risk, stressful things such as injuries that they're dealing with, then there's an automatic question and check-in about how are you dealing with this, as a person, how is this sitting with you, kind of thing.
So what I'm hearing is that in the spectrum of care and how we're identifying it, we need to have really actionable plans for screening. So that seems really, really clear cut. Thanks for your guidance on that. How do we get the confidence of the coaches and all of the athletic staff and the student athletes to do screening? Sometimes they feel maybe you're invading on their privacy, or they aren't used to this concept of mental health screening, but they'll certainly do cardiac screening. How do you build the confidence on that?
I would say in my experience, it's primarily making sure that everyone understands the rationale and what the purpose and mission is with the screens. The only time I think that there's generally pushback is if there's a misunderstanding about what it is that is happening with the screening and why are we completing this at the time that we are. So I personally think most coaches and any support staff also want to pay attention to their own mental health. And so if we can meet them and explain what the challenges are that we're managing and why we're doing what we're doing, most of them are really appreciative, and there isn't much pushback. It's when there is a lack of communication and understanding that I think then there can be some concerns.
I couldn't agree more. I think it really is all about how the screening is introduced to the athlete. So I mentioned our mid-semester screening, fall and spring, and our mental health liaisons for each team are the ones who introduce that screening. So it's the very familiar, trusted face who is the one who's introducing this screening. What is it used for? The results aren't going to your coach. The results aren't going to determine, playing time, scholarship dollars, etc. Here's the purpose of it.
Yeah, great responses. Kim, you kind of touched on something which we aren't addressing formally, but have you seen schools use, or Claudia, you too, have you seen schools use screening tools for coaches?
I haven't, but I've experienced having the director of behavioral health come to coach meetings and talk about all of the different components of mental health and the things that might not just be affecting student athletes. So I think they aren't doing formal screens, but they're certainly being educated and providing opportunities to seek care for themselves, or to be referred, or to also just have a better understanding.
Yeah, I have not seen coaches screen, but talk about a high pressure job. And I think that is a profession that certainly could use that. And then the question comes, what do you do with positive results? If you, the athletic department, the team doctors, the team psychiatrists are not able to provide care for those because they're not under the cohorts for whom we provide care, then what happens with a positive result? So it's just those complexities that, of course, have to be dealt with before we can screen people.
Yeah, and that really goes outside of athletics because and really who in the school is managing the employed individuals. So just wanted to throw that out there. I know it was off script a little bit, but we hear so often about the self-care that coaches need. And on one of our very earliest Spotlight series, one of the coaches who had undergone mental health first aid training said how he had such a greater awareness of what's important in mental health, and it changed this whole concept of self-care. So I just want to keep that drumbeat in the background. It's not addressed by legislation, but it's something I think that it's important for us to keep talking about. My last question, there may be many in the audience who don't have anything really formally done in their campus from a screening point of view. They're just starting to get a sense of how to set up routine emergency mental health action plans. Kim and Claudia, let's go to the most basic level. So I'm at a campus, not sure, that I've identified all my licensed mental health providers, want to get screening started, don't know where to go. How can we start at Basics 101?
I certainly think that there are some validated screening tools that Dr. Reardon mentioned earlier that she's using in her practice that can be used by team physicians when they're meeting and clearing student athletes for the first time, or if they're seeing them on visits. So that's probably the foundational sort of beginning area where, several decades ago, we sort of realized we needed to include some of those questions on when we're onboarding student athletes. So there's always that opportunity to involve your team physician in screening and figuring out how that practice might work. That would be my first go-to response. But I think also going back to our original message, Brian, I do think involving the licensed mental health provider that is collaborating with your program and get them to help you with brainstorming of how might screening work with the way that your processes are in terms of how you're taking care of student athletes.
Totally agree. And so I would just say, in my humble opinion, if I were going to start a screening program, I would do it probably at preseason physicals, just for ease of implementation, and probably a PHQ-9 for depression, a GAD-7 for anxiety, and I would argue an eating disorder questionnaire should be included as well, just given the painful frequency of that disorder. Something like the beta-Q, which is a screening for eating disorders validated in athletes. So that's a starting point. for screening. And then not forgetting that our athletes are students at your respective colleges and universities, thinking about what is offered for the general student population in terms of if you're really starting bare bones, building up referral pathways, what are, crisis resources available, whatever's available for the general student population at your institution, presumably is available for your athletes too. So at a minimum, having those resources as a starting point and then layering on athlete-specific resources from there.
Well, this is great. Really can't thank you enough, Claudia and Kim, for being here, for your expertise and giving your time. And for all of our audience, we're going to be returning soon for the second installment on the SSI Spotlight on mental health action plans. And we'll be getting much more granular in terms of how we're taking individuals through the pathways for receiving routine and emergency mental health care. So thanks for joining us, and we look forward to being with you soon. So till next time.